Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, The Role of Troponins I and T and NT-proBNP in Monitoring Cardiac Safety of Early-Stage HER2-Positive Breast Cancer Patients Receiving Trastuzumab, a HERA Cardiac Marker Substudy by Dimitrios Zardavas et al. My name is Deepa Rangachari, and I am an instructor of medicine at the Beth Israel Deaconess Medical Center and Harvard Medical School in Boston, USA. My oncologic specialties are breast and thoracic oncology. HER2 overexpression is known to occur in some 15 to 20% of patients with breast cancer and renders a biologically aggressive phenotype which has been associated with poor outcomes. However, potent HER2 targeting therapies have transformed the landscape of this disease and become the cornerstone of effective and tolerable therapies for this subset of breast cancer patients. Trastuzumab is a monoclonal antibody targeting the extracellular domain of the HER2 receptor tyrosine kinase. Approved in 1998 by the U.S. Food and Drug Administration for treatment of patients with advanced HER2 overexpressing breast cancers, it was the first of now many targeted therapies used in the care of patients with molecularly defined solid tumor malignancies. Cardiac toxicity is a relatively infrequent but potentially serious adverse outcome associated with trastuzumab use. The spectrum of cardiac toxicity has ranged from asymptomatic decline in left ventricular ejection fraction, hereafter referred to simply as ejection fraction, to clinically overt symptomatic heart failure. In patients receiving concurrent anthracycline and trastuzumab, the reported incidence of cardiac dysfunction may be as high as 27%. However, in studies of single-agent trastuzumab or trastuzumab given sequentially after anthracyclines or in the setting of lower cumulative anthracycline doses, rates of cardiac dysfunction may be as low as 2 to 3%. Data informing the optimal strategy for baseline and subsequent cardiac surveillance in patients undergoing trastuzumab-based therapy are wanting. Current clinical practice relies on serial evaluation of ejection fraction, typically at baseline and every 3 months during adjuvant therapy in the curative setting. However, decline in ejection fraction may be a late manifestation of cardiac injury. It may also be associated with delays in introduction of effective heart failure therapies and inter-observer variability in ejection fraction measurements. Moreover, current image-guided methods do not adequately facilitate identification a priori of individuals who may be at greatest risk. Towards this end, there has been great interest in the use of biomarkers for upfront risk stratification and subsequent monitoring. The I and T isoforms of cardiac troponins, which are released from cardiomyocytes during episodes of injury, and natriuretic peptides, which are secreted in response to wall stress and elevated left ventricular filling pressures, have been most studied. A variety of predictive clinical factors have also been evaluated, including older age, prior or concurrent anthracycline use, chest radiation, antecedent systolic cardiac dysfunction, increased body mass index, hypertension, diabetes, valvular heart disease, and coronary artery disease. However, most have been best vetted for prediction and assessment of anthracycline-mediated cardiac toxicity. It is further important to note that mechanisms and manifestations of cardiac toxicity incurred with anthracycline exposure are inherently different from those associated with trastuzumab. Anthracycline-mediated cardiac dysfunction is generally better understood, provoked by free radical formation and oxidative injury, and is dose-dependent. In contrast, trastuzumab-mediated cardiac toxicity is not dose-dependent, frequently associated with asymptomatic decline in ejection fraction, and commonly reversible with drug discontinuation in standard heart failure pharmacotherapy. Re-challenge is also generally feasible and tolerated. Existing evidence suggests that prior anthracycline exposure may render cardiomyocytes particularly vulnerable to subsequent HER2 blockade and injury. In the article that accompanies this podcast, Dr. Zardavas and colleagues present a pre-planned sub-study analysis of cardiac outcomes from the trastuzumab after adjuvant chemotherapy in HER2-positive breast cancer, or HERA trial, initially published by Piekart Gebhardt and colleagues in the New England Journal of Medicine in 2005. This was a phase 3 randomized study of adjuvant trastuzumab for patients with HER2 overexpressing early-stage breast cancers who had completed standard neoadjuvant or adjuvant chemotherapy. A total of 5,081 patients were randomized to receive observation alone or 1 versus 2 years of post-chemotherapy trastuzumab. Comparable disease-free survival in each of the trastuzumab-receiving groups and improved disease-free survival as compared with the observation-only group have established 1 year of trastuzumab as the current standard of care in the adjuvant setting for these patients. Zardavas and colleagues serially assessed cardiac troponins I and T and the amino-terminal fragment of brain natriuretic peptide, hereafter referred to as NT-proBNP, in conjunction with ejection fraction assessment at baseline and then again at regular intervals through year 3. Changes from baseline and biomarker level during the course of treatment were assessed against cardiac endpoints or a significant decline in ejection fraction, the latter defined as a drop of at least 10% in ejection fraction from baseline and to below 50%. The author's primary objective was to investigate the predictive value of these biomarkers for progression to symptomatic heart failure in patients with a significant decline in ejection fraction. Serum samples coupled with ejection fraction assessments were evaluable for 452 patients out of the original study population. 81% of patients were Caucasian and most were postmenopausal with a median age of 50. 94% had been previously treated with an anthracycline and most completed the planned course of trastuzumab therapy. Overall, 46 patients, or 10%, experienced a significant decline in ejection fraction, with 32 patients experiencing any cardiac endpoint, defined as symptomatic heart failure and or significant decline in ejection fraction. Of these, 3 patients, all receiving trastuzumab, experienced moderate to severe symptomatic heart failure in conjunction with ejection fraction decline. 90% of events occurred in the trastuzumab receiving cohorts. Elevated baseline troponin I and T were noted in a similar proportion of patients receiving and not receiving trastuzumab, approximately 12 to 13% with troponin I elevation and 24% with troponin T elevation in each group. Moreover, most observed troponin elevations were present at baseline. Mean and absolute troponin values did not increase compared to baseline during subsequent therapy with trastuzumab, and the absolute change from baseline to highest troponin prior to or concurrent with significant ejection fraction decline was small. In patients experiencing a significant ejection fraction decline with absent or mild symptoms of heart failure, acute recovery rates were greater than 70%, regardless of troponin values. Changes in NT-proBNP were not predictive of any cardiac endpoints, as there was a high degree of variability at any given time point. Cox regression analysis indicated a 2.4 to 4.5-fold increase in risk of ejection fraction decline with troponin I or T elevation. As this risk was comparable irrespective of trastuzumab, the authors conclude that there was no marked contributory effect of trastuzumab itself. Multivariate analysis incorporating age, hypertension, smoking status, and prior anthracycline therapy did not indicate any added impact on the association between troponin levels and ejection fraction. This study leads to several key conclusions. First, there were relatively few evaluable cardiac events in this population of patients with significant prior anthracycline exposure and subsequent trastuzumab use. Second, due to these small numbers, it is not possible to ascribe any predictive value to the studied biomarkers for identification of patients with a decline in ejection fraction who may then be at risk for subsequent development of symptomatic heart failure. Third, elevation of troponins prior to trastuzumab administration is associated with an increased risk of ejection fraction decline, but likely largely reflects the effects of prior anthracycline exposure. Lastly, as most patients experiencing any cardiac event subsequently recovered, no conclusion can be made regarding the prognostic value of elevated biomarkers with regards to long-term cardiac outcomes. Notable limitations of the current study include small sample size representing less than 10% of the original HERA population, low number of cardiac events, and mostly Caucasian patients. While the current analysis adds to our understanding of biomarkers and cardiac toxicity in the setting of prior anthracycline exposure, it will be important to develop strategies to better predict and monitor for trastuzumab-induced cardiac toxicity in patients not receiving anthracyclines previously, as relatively little is still known in this regard. The practical reality of caring for an aging, comorbid population that may benefit from less toxic anthracycline-sparing regimens, especially when coupled with potent HER2-targeting therapies, has created an ongoing need for timely, cost-effective, and reliable strategies for upfront risk stratification and ongoing safety monitoring when trastuzumab is indicated. Notwithstanding, Zardavas and colleagues should be congratulated on their important contribution to this highly relevant body of literature. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.